in Berlin. So it is a great pleasure to welcome Professor von Hahn from Hanover, who will be my successor. And he is also here at the Endoclub. Mr. von Hahn, could you please give the demonstration? Thank you for your kind introduction. Hello, everybody. And I'm really pleased to work here in Barmbek to see where I'm going to be working in the future. So this brings me to the case. I'm doing an endosonography of a patient who I will talk about in a minute. Britta and Isabel will assist me, and Ms. Ehrenfeld is the anesthesiologist. This is an 86-year-old female patient who since 2013 has had a small polycystic pancreatic lesion. At the time it was 13 millimeters, relatively small. It was observed for a while, nothing much happened, but then it grew over the last couple of years. And now the patient developed symptoms, and she has a bell-like pain in the upper abdomen, and that would fit the lesion, and she presented with a wish to receive therapy. So we are moving in from the left. We have the pancreatic corpus caldum transition. We use an Olympus Echo endoscope with a Hitachi ultrasound device that is completely compatible after the merger. You see the pancreatic duct structure. Here you see there is no dilation of the duct. The pancreas looks rather normal, and this fits the description of the patient. The patient has not had a history of pancreatitis and typical pancreatic pain, with the exception of the last couple of weeks. So now let's move a little bit towards the left of the body of the patient. This is the tail of the pancreas. The duct looks rather normal, no exceptional or abnormal findings. But if you go to the right side, further down, the duct moves out, and what you see here is some strange formation in the pancreatic head region. And this is the lesion we're talking about that has clearly grown in the last couple of years, and we would like to have a look at that. Let's simply zoom out and see a large polycystic version, small cysts, larger cysts in the center. There might also be solid parts to it. So the pattern is that the pancreatic duct seems to move off or branch off. It might be under the lesion, and I cannot see it well in the ultrasound. Now the first step is to measure the lesion. I try to focus on the larger cysts, and then we measure the actual dimensions of the lesion, and maybe also the largest cyst here on the left. 38 millimeters. So it's a clear increase over the last couple of years. So I take another image, release again. Now the question is, what is it? We estimated that it could be a serous cystic adenoma, and this might be quite a correct description, but what doesn't fit into the picture is that it is near the pancreatic head. It's not a typical localization. And it doesn't have a capsule either, which it would not corroborate the mucinous cystic adenoma. The morphology is more that of a cyst in cyst pattern, and the diagnostic tool is contrast medium sonography, where the solid parts and the septum could be detected, and that could help us see whether it's a neoplasm or what the actual origin of the lesion is. Now let's move in and get started. Now we work with the contrast medium mode, and it looks quite good. So now contrast medium will be injected. One ampulla of Sonoview. Now we wait for the contrast medium to concentrate, and gradually it's visible. So I just go over the entire lesion and I see it is intensively vasculated. So there is a solid part to it, I would say. The cysts, as expected, are free of contrast medium. They were also hypoechoic. So thank you very much. I think we can lose the KM mode and go back to the B image and maybe zoom out a little bit. Now the question is, what do you do with this? What is the entity? By way of summary, I could say it's a cyst and cyst pattern. The largest cysts are more than 20 millimeters inside. They're located in the pancreatic head region. So that is maybe a further development of the previous diagnosis, oligocystic serous adenoma, not a malignant tumor. And also this sudden growth fits the pattern of this lesion. And this is a strong argument in this patient because the patient has symptoms recently and she's suffering from these symptoms. If that wasn't the case, we wouldn't have to act at all. But in this case, my colleagues in Barbeck agreed with the patient that surgical therapy should be applied to this lesion, and I can understand that in this situation. What did the papilla look like? That's my question. Mr. van Hahn, what does the papilla look like? Well, we have some time. Maybe we can go there. It has a relatively large duodenal diverticulum, and that is, the patient has a diverticulum. The papilla is next to a juxtapapillary diverticulum, and we should be able to see it. Could you give us the endoscopic view too? So we are moving forward. It's not always so easy. So you see the entry of the diverticulum on the left and on the right. We can move forward and let's see whether we can identify the papilla. But Stefan, do you think this is an IPMN with a fish mouth when the pancreatic duct is lean? Well, now this is about the surgical indication. That's another point that might clarify the situation and help you decide in favor of surgery. But if there is no fish mouth symptom, then you would still operate. And were the symptoms then associated with pancreatitis? Well, there was no surge of pancreatitis because the lipase was not increased. But what's typical for this lesion is that you have to be humble when looking at it, because you can never be completely sure. Symptomatic, increase in size. In a case like that, it is difficult to reject the wish of the patient to get surgical therapy. Well, it's probably difficult to see the papilla. No, we won't be able to show you that probably because of the oblique position of the endoscope. Anyway, we believe you that there is no fish mouth situation, and tomorrow in the histology we will see how large the finding in the pancreas is. Thank you very much for your first presentation at EndoclubNord, and all the best for your career in Barmbek.